Hi, a very good evening. So this live session will dedicate for textbook discussion, right? So the topic for this live session's discussion is periodontal pocket from Carranza, either 9th edition or 10th edition or any recent edition which is available for you, right? So I'll be following 10th edition. So Carranza 10th edition, topic periodontal pocket, chapter 27, right? So before we start, I would like to start with a beautiful inspiring quote. For all those who complain saying that we all have problems in life and we're really finding it tough and difficult to move forward, here is the best quote. I can't change the direction of the wind, but I can adjust my sails to always reach my destination, as quoted by Jimmy Dean. So you have that in the comments now. I can't change the direction of the wind, but I can adjust my sails to always reach my destination. How relevant it is. Yeah. So a very good evening, all of you. Hi Nidhi. Hi Jias. Hi Abhishek. Hello Mauni. Hi Pritika, Regina, Ravina. Very good evening. Yeah, is it streaming live? Okay. Hi Nikhil. Hi Ramesh, a very good evening. Hope you have checked your mail. Right, so we'll start off. See, before starting today's live session, I would like to briefly give you the objective of starting this live session on textbook discussion. So as we have previously mentioned, right, so as I mentioned previously, the objective of starting this textbook discussion is to familiarize ourselves with various literature pertaining to standard textbooks, right? So most of us are not having the habit of referring standard textbooks, especially when during our undergraduation, right? So the objective of this session, of this Wednesday's session, is to mainly familiarize ourselves with various standard textbooks of different subjects, and so that with the hope that we get used to reading these standard textbooks and absorb as much relevant, important and authentic information as possible, right? Because the information given here has lot many references. It's valid not only from the university entrance point of view, but also a theoretical point of view and also clinical point of view, right? So the objective is to maintain standards while we are learning, right? So standards can be incorporated and can be improved by following books which are of very good standard, right? So obviously I've discussed various standard books, and also I keep on sending mails to all those who ask me regarding the list of books, right? So you can just drop a mail. I mean, as much as possible, those books which are considered to be standard, I'll drop a mail and you all can follow. We all can follow, right? So this week, just one second. Yeah. So this week we'll be having a live session on periodontal pocket. So already, we also have some pictures. I'll display some pictures also while the discussion is going on, right? So we'll just jump off into the discussion. It's already 7:35, right? So it will definitely take a lot of time because this topic is very vast and there are a lot many important points to be covered, right? So I have marked all those important points, and also we'll just go through the entire text in brief and we'll try to complete off the session as soon as possible, maybe within 90 minutes or within 80 minutes, right? So coming to the topic for discussion, the periodontal pocket, right? So once again, hi, a big hi to all of you, a very good evening. Hi Preeti, hi Abhishek, Prajakta, hi Shamla, hi Megha, hi Prithvi, Kirti, Pooja. Hi, a very good evening. Right, so hope you have this hard copy with you and also a marker, preferably a marker, right? And also a note so that you can make a note of important points when we come across them, right? Hi Deepthi, very good evening. So periodontal pocket. So periodontal pocket, as you can see in the introductory part of this chapter, it's defined as the pathologically deepened gingival sulcus. So normal gingival sulcus, the depth would be around 1.5 to 3 mm, right? So normal sulcus depth, sulcular depth. Whereas in case of periodontal pocket, there is actually deepening of deepening of gingival sulcus, which is nothing but pocket formation, right? So to define, periodontal pocket is pathologically deepened gingival sulcus, and it's one of the most important features of periodontal disease. And then we have a classification, right? So classification as such is very important from theoretical point of view, theory exams, and also in the entrance point of view. We'll just go through a few important points pertaining to classification. So classification, we have true pocket as well as a periodontal true pocket, as well as false pocket or pseudo pocket, and also based on the extent of the defect, depending upon the supracrestal or infracrestal. With relation to the bone, we have suprabony pockets as well as infrabony pockets. So as you can see here, deepening of gingival sulcus may occur by coronal movement of gingival margin, or apical displacement of gingival attachment, or by a combination of these two processes. So let me just show you the image which I have obtained from Carranza itself. Hope it's clear. Yeah. Right. So as you can see here, so that's what we are discussing now. You can see two arrows here, one arrow pointing upwards, the other arrow pointing downwards, right? So deepening of gingival sulcus may occur either by coronal movement of gingival margin, or apical displacement of gingival attachment, or a combination of these two processes, right? So that's clearly represented in this illustration, right? And gingival pocket, it's also called as pseudo pocket. The reason why we call it as a pseudo pocket is, in gingival pocket there is no migration, apical migration of epithelial attachment. That's very, very important, right? Hence it's considered as pseudo pocket. So in gingival pocket there is overgrowth of gingiva, so clinically there seems to be formation of pocket, but that's not a true pocket. We consider a pocket to be true when there is apical migration of epithelial attachment. So that's very important. So gingival pocket, a pseudo pocket, this type of pocket is formed by gingival enlargement without destruction of underlying periodontal tissues. The sulcus is deepened because of the increased bulk of gingiva, right? Now, periodontal pocket is the type of pocket which occurs because of the destruction of periodontal tissues. Progressive pocket deepening leads to destruction of supporting periodontal tissues and loosening and exfoliation of teeth. And so the remainder of the chapter will focus on this type of pocket, right? So I have shown you the illustration, right? So pocket formation or deepening of gingival sulcus can happen in two directions, right? One is coronal movement of gingival margin, or apical displacement of gingival attachment. So this is very, very important. Now, coming to two types of periodontal pocket. Now we have seen what is true pocket and what is pseudo pocket. Now let's see in true pocket, that is in periodontal pocket, what are the different types of pockets that are present clinically. So we have suprabony pocket and intrabony pocket. So as the name itself indicates, suprabony pocket is the pocket in which the bottom of pocket is coronal to the underlying alveolar bone, right? So the bottom of the pocket or the base of the pocket is present coronal to the underlying alveolar bone, whereas intrabony or infrabony pocket, in which the bottom of pocket is apical to the level of alveolar bone, right? So I'll just show you the diagrams here also. We have few illustrations given here, right? So as you can see here, let me just read out the legends for you, those who are not having the textbook. So we have different types of periodontal pocket, as you can see. So we'll start with this one, right? The first one. So this is gingival pocket where there is enlargement of gingiva. So this is a kind of pseudo pocket. Whereas the middle one, that is suprabony pocket, the base of the pocket is coronal to the level of the underlying bone, as you can see. So this is the base of the pocket, this is the bone level, right? So the base of pocket is coronal, whereas here the base of the pocket is apical to the crestal level of bone, right? So that is infrabony pocket. So intrabony pocket is, in this type of pocket, as you can see, the lateral pocket wall lies between the tooth surface and the alveolar bone. So this is the pocket lining, right? So the pocket lining, the lateral wall of pocket lies between the bone on one side and the tooth surface on the other side, right? So these illustrations, once you go through these illustrations, the concept will be very much clear. Rather than imagining or just visualizing them in air, it's always better to go through the illustrations. Clinical pictures are much more better, right? They're much more superior and they enable us to understand the concept in a simplified manner. And now coming to the synonyms. Suprabony pocket is also called as supracrestal or supraalveolar pocket, whereas intrabony pocket is also called as infrabony pocket or subcrestal or intraalveolar pocket. Just make a note of these synonyms, right? And then we also have a classification of pockets based on the number of tooth surfaces involved. So as you can see here, based on the number of tooth surfaces involved, the first one is simple pocket where you have involvement of only one surface. The second one is two surfaces, right? That is compound pocket. And the third one is, for example, a spiral pocket which starts on one surface and goes round spiral and opens up somewhere into the gingival sulcus. That is complex pocket. So according to the involved tooth surfaces, we have simple pocket, compound pocket and complex pocket. So these are in brief the classification of pockets. Alright, I hope it's clear. Now let's move on to the next topic. That is clinical features, which is the most important, because we need to understand the clinical features and also try to correlate the findings histologically. Why do we see some kind of clinical features which are specific to periodontitis, and what are the histological changes that are happening within the tissues corresponding to the clinical level, right? So we'll go through that in brief now. I hope you guys are following, right? I mean, am I audible? Is it clear? I mean, can I proceed at the same pace, or do you want me to alter the pace? Hi Ashok, Swapnil, hello. Hi Bernice. Bernice, it's chapter 27. Page number is not there here, I'm sorry. But it's chapter 27 in 10th edition. Hi Viral, very good evening. Hi Devarshi. Description regarding combined pocket. You mean combined or compound? Hi Kumari. Okay Megha, thank you for the page number. It's page 435. Is it 10th edition, Megha? Right. So since we have seen the definition of pocket and also the classification of pocket, now let's proceed into the clinical features, right? So clinical signs suggest the presence of periodontal pockets. I mean, the clinical signs include bluish red, thickened marginal gingiva, or bluish red vertical zone from the gingival margin to the alveolar mucosa. There can be gingival bleeding, suppuration or pus discharge. There will be mobility, diastema formation, and symptoms such as localized pain or pain which is deep in the bone. So deep in the bone kind of pain sensation is seen in case of periodontitis, right? So these are the clinical features, right? Just imagine, I mean, you would have seen some periodontal cases in your clinic or in your department, right? So you can just recollect those, or you can best ways to go through the clinical pictures, right? So bluish red or thickened marginal gingiva, bluish red or vertical zone from the gingival margin to alveolar mucosa, bleeding, suppuration, tooth mobility, diastema, and symptoms such as localized pain or pain which is deep in the bone, right? And the only reliable method of locating pockets is by careful probing. So in e-classes, yesterday I posted one video where we have something called as probing stroke. We have basically three types of stroke: exploratory stroke, we have scaling stroke, and root planing stroke. And along with that, we have something called as probing stroke, which is nothing but upward and downward movement of a probe in a given periodontal pocket, right? So that's what they mentioned it here also. Now, coming to the correlation of clinical and histopathologic features of periodontal pocket. So whatever we see clinically, so what's happening exactly at the histological level, right? So coming to the first clinical feature, gingival wall of pocket presents various degrees of bluish red discoloration, flaccidity, smooth shiny surface, and pitting on pressure. So flaccidity is nothing but losing that tense nature. So flaccidity is soft and limp, which is not firm. A tissue which is not firm, we call that as flaccid. So gingival wall of pocket presents various degrees of bluish red discoloration, flaccidity, smooth shiny surface, and pitting on pressure. and the corresponding histologic changes include the following. The discoloration, which we're talking about, bluish red or bluish color or reddish color, it's mainly because of stagnant circulation. The circulation is stagnant, it's stopped. The flaccidity is mainly by the destruction of gingival fibers, so the tone of tissue is lost. And the smooth shiny surface which we see clinically is because of atrophy of epithelium and edema. And the pitting on pressure is obviously because of edema and degeneration. So these are some of the correlating features, clinical signs and histological changes. Now coming to the next clinical sign, less frequently gingival wall may be pink and firm. Right? So that's because of fibrotic changes. So in such cases, fibrotic changes predominate over exudation and degeneration. So remember, periodontitis can progress in two directions. As such, these two are not separate entities. They are all the extreme ends of the same disease, that is periodontitis. One extreme end you have this fibrotic changes. The other extreme end you have this edematous changes, pinkish edematous changes. Right? So we have two extreme ends of the same pathology. Right? So gingival wall may be pink and firm when there are histologically fibrotic changes which predominate over exudation and degeneration. Right? So we'll leave that there. And the third clinical feature, bleeding is elicited by gentle probing of soft tissue wall. So bleeding on probing, histologically the correlation is, the bleeding is mainly because of increased vascularity, thinning and degeneration of epithelium, and proximity of engorged vessels to the inner surface. So that's the reason why we have bleeding on probing. And fourth clinical feature, when explored with a probe, the inner aspect of pocket is generally painful. It's because pain on tactile stimulation is caused by ulceration of inner aspect of pocket wall. Because of degenerative changes, atrophy of the epithelium, there can be ulcer formation along the inner aspect of the pocket lining. So there can be pain on probing the pocket wall clinically. And the fifth clinical sign or feature, in many cases pus may be expressed by applying digital pressure, finger pressure. Pus occurs in pockets with suppurative inflammation of inner wall. So that's the histologic corresponding feature, right? And also remember, the amount of pus that's formed doesn't tell us the information regarding severity of disease. It means if you see a case where there is more pus discharge, it doesn't mean that there is a severe infection there. So pus discharge has nothing to do with the severity of infection, which we'll discuss consecutively, right? So we have all that information given here very clearly. So these are some of the clinical features and correlation between clinical features and histopathologic features of periodontal pocket. So this is very, very important, right? Now let's briefly go into the pathogenesis, only the important key points, right? So coming to pathogenesis, the initial lesion in the development of periodontitis is inflammation of gingiva in response to bacterial challenge. So that's obviously understood. Healthy gingiva also contains microorganisms, mostly coccoid cells and straight rods, whereas diseased gingiva is associated with increased numbers of spirochetes and motile rods. Right? So pocket formation starts as an inflammatory change. Just remember, no matter what kind of infection or whatever it is, whenever there is any noxious stimuli acting on the surface of a living organism, the common response which we can expect is inflammation, because inflammation is nothing but localized response of a vascularized living tissue to some kind of noxious stimuli, right? So because of presence of bacteria in plaque, because of a plaque challenge, because of presence of calculus, there can be inflammation, and this is a starting point for the pathogenesis of pocket formation, right? So pocket formation starts as an inflammatory change in the connective tissue wall of gingival sulcus. The cellular and fluid inflammatory exudate causes degeneration of surrounding connective tissue, including the gingival fibers, and just apical to the junctional epithelium, collagen fibers are destroyed, and that's the reason why there is apical migration of junctional epithelium. So because of these inflammatory changes, the collagen fibers are being destroyed, even apical to JE, junctional epithelium. So there is gradually apical migration of junctional epithelium, leading to progressive increase in depth, or the pocket becomes deeper as the disease progresses, right? Now there are two mechanisms that are considered to be associated with loss of collagen. Just make these points, make a note of these points. The two mechanisms include, the first one is enzymatic degradation. So we have certain enzymes like collagenases and various enzymes that are released by various cells, various inflammatory cells such as fibroblasts, polymorphonuclear leukocytes, macrophages, etc. So these enzymes are called as MMPs, matrix metalloproteinases, which destroy collagen. As a result, all these pathologic changes to happen. So that's one mechanism. The other mechanism is phagocytosis, right? So fibroblasts they phagocytize collagen fibers by extending cytoplasmic process to the ligament cementum interface and degrade the inserted collagen fibrils in the fibrils of cementum matrix. So there are two mechanisms by which the collagen is destroyed. So in the pathogenesis, in response to bacterial challenge. So the two mechanisms, the first one is, as mentioned, enzymatic degradation by presence of matrix metalloproteinases, which are released by PMMs, leukocytes, which are released by macrophages as well as fibroblasts. And the second mechanism is phagocytosis by the fibroblast cells. So as a result or as a consequence of loss of collagen, the apical cells of JE proliferate along the root, extending finger-like projections 2 or 3 cell in thickness. So this is very, very important. So this is a starting point. So as the collagen is destroyed, so junctional epithelium, beneath the junctional epithelium we have something called as connective tissue, right? So as you can see here in this illustration, as you can see, so we have this junctional epithelium here. So the collagen underneath is destroyed. As a result of this destruction, junctional epithelium migrates apically further into 2 or 3 cell thickness, extending finger-like projections, right? So as a result, we have this deepening of the base of the periodontal pocket. The kernel portion of JE detaches from the root surface as the apical portion migrates. That's all fine. And here we have another important point. As you can see here, the polymorphonuclear leukocytes are not joined to one another. See, since there is inflammation, in acute changes we can expect neutrophils, right? So that's the first response we see. Whereas in chronic cases we find these macrophages and lymphocytes. So whenever there is infiltration by the neutrophils, so the junctional epithelium is invaded by all these cells, connective tissues are invaded by all these cells, and these neutrophils, they do not adhere to one another. I mean, we do not find desmosomes there. So intercellular attachment is absent. And when the relative volume of neutrophils reaches approximately 60% or more of junctional epithelium, the tissue loses cohesiveness and detaches from the tooth surface. So as the junctional epithelium migrates apically, it has to detach coronally and it has to migrate apically and attach there, right? So detachment or loss of cohesiveness is seen when the neutrophils volume is 60% or greater. So that when when this threshold is crossed, the cohesiveness is lost and the JE migrates apically. So this is very important. Next, extension of junctional epithelium along the root requires presence of healthy epithelial cells. Marked degeneration or necrosis of junctional epithelium impedes rather than accelerates pocket formation. So if the junctional epithelium is destroyed completely, if it is necrotized, then there can't be deepening of the pocket, because for the deepening of the pocket, for the junctional epithelium to migrate apically, it needs, obviously there has to be healthy cells that have to be maintained in order to have and more apical attachment, right? So just remember, marked degeneration or necrosis of JE, we might assume that the pocket deepens, but on the contrary, marked degeneration or necrosis of JE impairs rather than accelerates pocket formation. So I hope the logic is understood, right? Next. So that's pertaining to the pathogenesis. So very well given. And then as you can see here, as a continuation of this, the degree of leukocyte infiltration of JE is independent of volume of inflamed connective tissue, and this process may occur in gingiva with only slight signs of clinical inflammation. So this is very important. Even though clinical gingiva seems to be having only a little amount of inflammation, but there can be a lot of damage happening inside the pocket lining, right? So the degree of leukocyte infiltration of JE is independent of the volume of inflamed connective tissue, and this process may occur in gingiva with only slight signs of clinical inflammation. So what we see clinically is only minimal, but what's happening inside histologically, there is much more destructive phenomena that's happening. It's similar to that of radiographs, right? When you take IOPA, it's standard two-dimensional IOPA. What you see, I mean, the size of the periapical lesion, that's what they say. What you see clinically in the radiograph, it's smaller, but histologically, the destruction is much more longer, much more larger, because what you're seeing on radiograph is past. But the present, there is much more destruction, because for the for the radiation to pass through these cortical bones, there is some hindrance there. So what you see radiographically is miniature version of what's actually happening clinically, and that can be detected only through histologic sections, right? So similarly, we have the same kind of correlation here also. So I'll just try to summarize this entire pathogenesis as described here. With continued inflammation, gingiva increases in bulk, crest of gingival margin extends coronally, junctional epithelium continues to migrate along the root and separate from it. The epithelium of lateral wall of pocket proliferates to form bulbous cord-like extensions into the inflamed connective tissue. Leukocytes, edema from the inflamed connective tissue infiltrate the epithelial lining of pocket, resulting in various degrees of degeneration and necrosis. The transformation of gingival sulcus into a periodontal pocket creates an area where plaque removal becomes impossible and feedback mechanism is established. So there is plaque accumulation, and the situation worsens progressively, right? So that's in brief regarding pathogenesis, right? I hope it's clear. So that's very, very important, and that's quite interesting to know what exactly is happening. It's simple. There is inflammation. In response to bacterial challenge, there is inflammation, and because of the changes, because of the accumulation of cells, infiltration of cells, we have this destruction of collagen, migration of junctional epithelium, coronal shift of the gingival margin because of increased bulk of gingiva due to accumulation of fluid like edema, which is common in case of inflammation. The cardinal signs of inflammation, as you all know, they are rubor, calor, tumor, dolor, and functional lesion, right? Now, next let's briefly go into the histopathology, soft tissue walls, and other details. And before that, let me just take a 2-minute break and go through the comments which we are getting in. Hi Sadhana. Suprabony pocket, shallow periodontal pocket. Yeah, obviously, because suprabony pockets we find or we see. I mean, anyways, we're going to discuss the differences between suprabony and infrabony pocket. Don't worry, Regina. But anyways, as you asked me, suprabony pockets there is horizontal bone loss, whereas infrabony pockets there is vertical bone loss. So obviously, I mean, it's not clinically or theoretically possible to correlate saying that suprabony is shallow. We just can't say. Even suprabony pockets can be deeper, depends upon the particular clinical context. So actually there is no such correlation. We'll understand that as we go on in this discussion, right? See, the trigger factor is bacteria, which is present in the plaque. Poor oral hygiene, plaque accumulation, plaque, not even plaque, bacteria is the starting point. It's the challenge from the bacteria which initiates all these kinds of stimuli, right? So inflammation is mainly because it's seen mainly because in response to the bacterial challenge. Yes, Ben is rightly pointed out. It's plaque accumulation. Yeah, presence of microorganisms is not sufficient, but that would be the initiating factor. Definitely we have various other modifying factors, but microorganisms are the starting point. We're not saying that it's only because of microorganisms, but microorganisms are the starting point. We have various other factors, patient's oral hygiene and anatomical difficulties or anatomical limitations, or many factors can be there. I mean, systemic diseases, and also we can say smoking, right? We have many factors which alter and modify the progression of pocket, right? We'll discuss all that subsequently. Right. So now let's move on to the next section, that is histopathology. So histopathology as such, we'll just go in brief, right? Only the key points. Soft tissue wall. So as we have discussed, the connective tissue is edematous, infiltrated by inflammatory cells, plasma cells. Approximately, make a note of it, approximately 80% of the cells that are found are plasma cells, because periodontitis as such, it's a chronic disease, right? So plasma cells are seen approximately in 80%, followed by lymphocytes and scattering of neutrophils. Blood vessels become engorged, dilated, increase in number. Okay, there can be necrotic foci, and junctional epithelium, which is normally 400 microns or 500 microns, is reduced to a thickness of only 50 to 100 microns. So you can just make a note of these points. So corona-apical length of junctional epithelium is reduced to only 50 to 100 microns. And also, we have another important point, the next para. The most severe degenerative changes in periodontal pocket are seen along the lateral wall of the pocket, right? Okay. And also they mentioned that the severity of degenerative changes is not necessarily related to pocket depth. Ulceration of lateral wall may occur in shallow pockets, and deep pockets are occasionally observed in which lateral epithelium is relatively intact or shows only light. So that's what they're saying. The severity of degenerative changes is not it's not related to pocket depth. Even in shallow pockets, you can have lot many degenerative changes, but even in deep pockets, you can have only minimal degenerative changes. So we have various other factors which control or which affect these kind of responses. It has nothing to do with the pocket depth, right? And we have a lot many histopathologic images here. You can just have a look at them, various infiltrations into the connective tissue and also into the overlying epithelium. And bacterial invasion, they mention few microorganisms, just make a note of them. We mainly see filaments, rods and coccoid organisms. So we have predominantly gram-negative organisms, that's very important. So gram-negative organisms are predominantly seen, and Hillman et al. Have reported the presence of Porphyromonas gingivalis, Privitella intermedia in the gingiva of aggressive periodontitis. So aggressive periodontitis, Porphyromonas gingivalis, Privitella, also AA bacteria, Actinobacillus actinomycetum comitans, right? And some bacteria from the connective tissue, they traverse the lamina, basement lamina, and invade the subepithelial connective tissue. I mean, from the sulcus, they invade the connective. I mean, they invade the epithelial attachment and then they invade into the connective tissue, right? So that's all fine. And we have few SCM images also, TEM images, transmission electron micrograph, 8000 magnification. As you can see, presence of bacteria within the cells of epithelium, right? Yeah. Next, we have this microtopography of gingival wall. So gingival wall, when you take an SCM, we find different areas, and these areas have a diameter of around 50 to 200 microns. And the different areas that are found are areas of relative quiescence, areas of bacterial accumulation, areas of emergence of leukocytes, areas of leukocyte bacterial interaction, areas of intense epithelial desquamation, areas of ulceration, and areas of hemorrhage. So as such, we don't find only one area. We have a mixture of different areas that are found depending upon the type of interaction that's happening there. So areas of relative quiescence, they show flat surface with minor depressions and molds and occasionally shedding of cells. Quiescence is where there is no much activity happening, right? And areas of bacterial accumulation, which appear as depressions on epithelial surfaces with abundant debris and bacterial clumps penetrating into the enlarged intraepithelial spaces. The bacteria that are found are cocci, rods, filaments with few spirochetes, mostly gram-negative organisms. Areas of emergence of leukocytes, where leukocytes appear in the pocket wall through the holes which are located in the intercellular spaces. Next, we have leukocyte bacterial interaction, where there is phagocytosis that's happening there. Areas of intense epithelial desquamation, where there is loss of epithelial cells. And areas of ulceration, because of loss of epithelium, there is ulceration, exposure of connective tissue, and followed by bleeding, that is areas of hemorrhage. So these are some of the areas whose dimensions vary from 50 to 200 microns, and this is pertaining to the microtopography of gingival wall, right? And yeah, science transfer, we have some interesting information here. The presence of bleeding on probing indicates that the bacterial subgingival plaque is causing inflammation. So, Regina, you have your answer here. Presence of bleeding on probing indicates a bacterial subgingival plaque is causing inflammation and ulceration of epithelial lining of pocket, and that periodontal breakdown is active. So, bleeding on probing indicates active disease. The evidence of purulent exudate is another indicator of disease activity. It has nothing to do with the severity of infection, but it means presence of suppuration, presence of pus indicates that the infection over there is in an active state. Although bleeding on probing is an early sign of gingivitis, occurring within 2 days of plaque initiating disease, it's often present throughout the disease progression. And elimination of gingivitis-induced gingival bleeding on probing can be accomplished within 7 to 10 days of initial therapy. So it takes around 1 week to 10 days in order to reduce bleeding on probing, even after instituting the chemomechanical therapy or antimicrobial therapy or anti-plaque mechanical therapy, right? Now let's move on to periodontal pockets as healing lesions. It's very simple. So what they're saying is, periodontal pockets, as I said, we have two extreme ends. One extreme end, there is inflammation, edema, bleeding and all. The other extreme end, the gingival pocket is fibrotic and pink. So there are fibrotic changes happening to one extreme end, and to the other extreme end there are inflammatory changes, edematous tissue formation, right? So edematous pocket wall, fibrotic pocket wall are two variants of same disease, but they are not two separate entities, right? So that's very important. And the most degenerative changes in periodontal tissues occur adjacent to the tooth surface and the subgingival plaque. And coming to pocket contents, pockets obviously they contain microbes, saliva, various cells, blood, etc. right? So pockets contain microorganisms and their products such as enzymes, endotoxins, metabolic products, gingival fluid, food remnants, salivary mucin, desquamated epithelial cells, leukocytes. So plaque covered calicles usually projects from the tooth surface. Purulent exudate, if present, consists of living degenerated necrotic leukocytes, living or dead bacteria, serum, and scant amount of fibrin. The contents of periodontal fibers, okay, they are toxic, fine. So periodontal pocket, they contain the following, right? So we have this bacterial products, bacteria, we have pus, also we have this gingival fluid, and also we have calculus, salivary mucin, desquamated epithelial cells, various inflammatory cells like leukocytes, etc. right? And significance of pus formation, this is very important. There is a tendency to overemphasize the importance of purulent exudate and to equate it with severity of periodontal disease. So more the pus discharge, we think the more severe the periodontal disease is, but in fact it's not. Because it is dramatic clinical finding, early observers assumed that it was responsible for the loosening and exfoliation of teeth. Pus is a common feature of periodontal disease, but it's only a secondary sign. The presence of pus or the ease with which it can be expressed from the pocket on distal pressure merely reflects the nature of the inflammatory changes in the pocket wall. So they are reflecting only the inflammatory changes that are happening within the pocket wall, right? It's not an indication of the depth of pocket or the severity of destruction of supporting tissues. That's very important. Just make a note of it. So pus presence is not an indication of depth of pocket or severity of destruction of the supporting tissues. It only indicates that the disease condition is active, as mentioned before, right? Extensive pus formation may occur in shallow pockets, and whereas deep pockets may exhibit little or no pus, so there is no correlation as such, right? So they are mere reflection of the inflammatory changes that are happening within the soft tissue lining. And root surface wall, as a pocket deepens, collagen fibers embedded in cementum are destroyed. Cementum becomes exposed to oral environment. Collagenous remnants of sharpest fibers in cementum undergo degeneration. And remember, Viable bacteria have been found in roots of 87% of periodontally diseased non-carious teeth. So we find invariably bacteria on the root surface even in non-carious teeth which are compromised by periodontitis, right? And these bacteria can enter into the cementum, reach CDJ, and also may enter into the dentinal tubules, right? And okay, that's all fine. Bacterial products, endotoxins, okay. As you can see in the last para of this root surface wall, these changes manifest clinically as softening of cemental surface. As we discussed in one of the strokes, we have this root planing stroke where the objective is to remove this soft, friable, necrotic cementum and to make sure that we have a harder consistency of cementum so that there is reattachment that's possible, right? So these necrotic areas are removed by root planing until a hard, smooth surface is reached. So that's the objective of root planing. So the objective of root planing is also to remove the bacteria in the process of smoothing the entire root, right? And then we have decalcification and remineralization of cementum. So areas of increased mineralization, in fact what we assume is there will be only demineralization, but since the cementum is exposed to oral environment contains various ions, cations, and there can be greater potential for remineralization, right? So there is in fact increased mineralization probably as a result of an exchange on exposure to oral cavity of minerals and organic components at the cementum saliva interface, and the mineral content of exposed cementum increases, and the main minerals that are present include calcium, magnesium, phosphorus and fluoride. Micro hardness however remains the same. Okay, that's all fine. The development of highly mineralized superficial layer may increase the tooth resistance to decay. Right, you can just make a note of it because of increased fluoride content, right? Next, also we have, as I discussed, these hyper mineralized zones or increased mineralized areas. These zones form a thickness of 10 to 20 microns. So these hyper mineralized zones, the thickness is 10 to 20 microns with areas as thick as 50 microns. So the maximum thickness can reach up to 50 microns, but on an average it's around 10 to 20 microns, right? And then if you look at the next paragraph, also we have areas of demineralization which are often related to root caries, right? So exposure to oral fluid, bacterial plaque, proteolysis of remnants of Sharp's fibers, there can be root caries or senile caries also. Root caries is also called as senile caries. Unlike enamel caries, we had discussed about root caries in our e-classes, you can just refer that. We will know the differences between a normal enamel caries and root caries, and few of them are mentioned here. Unlike enamel caries, root surface caries tends to progress around rather than into the tooth, and cementum is least resistant to decalcification compared to enamel. And the active root caries lesions appear as yellowish or light brown areas frequently covered by plaque and have softened or leathery consistency on probing. Whereas inactive lesions are well defined darker lesions with a smoother surface and harder consistency on probing. And various organisms associated in root surface caries, as you all know, it's a standard question, Actinomyces viscosus, right? Other bacteria like Actinomyces nasalandi, Streptococcus mutans, Streptococcus salivarius and sanguineus and Bacillus cereus are also found, right? Yeah. Next we have this, okay. And subsequently it's mentioned that caries of cementum require special attention when the pocket is treated. The necrotic cementum must be removed by scaling and root planing until the firm tooth surface is reached, even if this entails extension into dentin, as we discussed previously, the objective of root planing. And also we have certain areas of cellular resorption of cementum and dentin which are common in case of roots which are exposed to oral cavity. Okay, now we'll just skip on and move on to the next important subtopic, that is surface morphology of tooth wall. Let me just show you the illustration first and then we'll move on to the discussion. Yeah. Regina, which book are you talking about? Because Carranza we have the reference here, right? So because they cite that the organisms are the starting point. Now, I hope you can see. right? So surface morphology of tooth wall. So the following zones can be found in the bottom of a periodontal pocket. So this is the bottom of the periodontal pocket, and this is from the gingival sulcus, right? So calculus and all you can see. So the first layer, which is maroon in color, I guess, yeah, that is cementum covered by calculus, right? And the second layer, which is a light brown in color, the second layer, that is attached plaque, whose dimension is 100 to 500 microns, right? Attached plaque which covers calculus and extends apically, probably 100 to 500 microns. Just make a note of these values also. And then third one from top, third one is white in color, that is zone of unattached plaque that surrounds attached plaque and extends apically to it. And fourth zone of attachment of junctional epithelium to the tooth, right? So junctional epithelium where it attaches to the tooth, this one, right? So usually in normal sulci the attachment is 500 microns, whereas in periodontal pockets it's less than 100 microns, as we discussed previously, right? So that's very important. And last zone we have these connective tissue fibers which are destroyed, right? So semi-destroyed connective tissue fibers may be apical to the junctional epithelium. So zones 3, 4 and 5 make up the plaque-free zone. And the total width of the plaque-free zone varies according to the type of tooth. Obviously it's wider in molars than incisors, and depth of pocket, it's narrower in deep pocket, right? We'll just move on to the next subtopic, right? So that's pertaining to the surface topography of the wall, right? Different zones, surface morphology of tooth wall, different zones which you can see in the bottom of a periodontal pocket. We have the cementum, we have the calculus covered by plaque, followed by attached plaque, and then zone of unattached plaque, and then junctional epithelium, followed by destroyed fibers of the connective tissue. So zone 3, 4, 5, they are plaque free zones. And then periodontal disease activity, as we have been mentioning, we have periods of quiescence, as we have seen microtopography. We have periods of quiescence, we have periods of exacerbation that's happening within, right? So in case of periods of exacerbation, that is when the lesion is active, we mainly find gram-negative motile anaerobic bacteria. That's very important, please make a note of it. So periods of exacerbation, gram-negative motile anaerobic bacteria, and periods of remission or quiescence, we have gram-positive bacteria, right? And site specificity, sites of periodontal destruction are often found next to sites with little or no destruction. Because, as I mentioned, for the migration to happen, for the migration of junctional epithelium to happen, we need to have healthy cells, right? So that's the reason why we have mentioned, it's mentioned here that periodontal destruction doesn't occur in all parts of mouth at the same time, but rather on a few teeth at a time, or even only on some aspects of a particular tooth at a given time. This is referred to as site specificity of periodontal disease. Sites of periodontal destruction are often found next to sites with little or no destruction. It means severity of periodontitis increases with development of new disease sites which have little or no destruction, and increased breakdown of existing sites. And pulp changes associated with periodontal pockets, obviously there can be damage or injury to pulp via the apical foramen or through the lateral canals, right? And relationship of attachment loss and bone loss to pocket depth. So, this is quite interesting, and they have mentioned here clearly in these images. Just have a look at these images and let's see what we can infer from these images. First, I'll project you this one. Yeah, just have a look at this image. I'll go through the description. So as you can see here, is that the first image? Yeah. As you can see in these three images, A, B and C, the pocket depth is almost the same. For example, assume that the pocket depth is 3 mm here. It's almost 3 mm in all the three. However, the attachment loss is greater in the C rather than in A. You can see that attachment loss, there is more apical shift, right? So even though the pocket depth is equal, the attachment loss greatly varies. It means attachment loss has nothing to do with the depth of the pocket. So that's the message we're getting from this image, right? And here, as you can see, the depth of pocket is different. It's deeper here, it's moderate, and it's very shallow, but the attachment loss is almost the same. You can see this junction, cement-enamel junction, same, right? So the attachment loss is same here, but the pocket depth is varying. So these illustrations clearly help us to understand the fact that the pocket depth has no relation with the attachment loss. Now let's look at the legend that's given here. Pocket formation causes loss of attachment of gingiva and denudation of root surface. The severity of attachment loss is generally but not always correlated with the depth of pocket. This is because attachment loss is something which is measured from the base of the pocket, whereas the pocket depth is measured something from the base of the pocket to the gingival margin. So because of this relative discrepancy in measurement, we have these differences, right? So pockets of same depth, just have a look at this image. Pocket of same depth may be associated with different degrees of attachment loss, isn't it? And pockets of same attachment loss are associated with different degrees of periodontal pocket. Attachment loss we are measuring from the base of the pocket, right? Whereas pocket depth we are measuring from the base of the pocket to the gingival margin, right? How we measure is also very important. And I love this particular part of periodontics because it's because of one of my staff, Dr. Santosh, who gave us the concepts in a very clear and crisp manner. He's explained us all these concepts very well, and not just me, but most of my friends and colleagues, we're all fans of his theory classes, right? He used to explain the concepts very well with logic. Yeah, that's fine. And then we have areas between. So what is the inference of these images? So I've shown you a few images, right? So what is the inference of this? Severity of bone loss is generally but not always correlated with pocket depth. Extensive attachment and bone loss may be associated with shallow pockets if the attachment loss is accompanied by recession of gingival margin, and slight bone loss can occur in deep pockets, right? So area between base of the pocket and alar bone, this is very important. We have something called as biologic width. We already have one video in e-classes also. So biological width is something which is equal to the depth of the epithelial attachment and the subjacent connective tissue, right? So it's approximately 2 mm, 0.97 mm of attachment loss, and we have something like 1.01 mm of connective tissue attachment, right? So we have roughly 1.97 mm. That's the biologic width, which is very important. Normally, the distance between, okay, that's all fine. The distance between the apical extent of calculus and the alar crest in human periodontal pockets is also constant, having a mean length of 1.97 mm. Make a note of it. And the distance, this is very, very important. The radius of action, we also have one question from this. The distance from the attached plaque to bone is never less than 0.5 mm and never more than 2.7 mm. It means the distance between the plaque and bone is between 0.5 to 2.7 mm, which is nothing but the radius of action of the enzymes of various bacteria. So these findings suggest that the bone resorbing activity induced by bacteria is exerted within these distances, right? The radius of action. Now coming to relation between the pocket to bone, we have already seen, right? So suprabony pockets, the base is kernel, infrabony pockets, the base of the pocket is apical to the crestal level. And we have these differences between intrabony and suprabony pockets, and then we have periodontal abscess. We'll just conclude with these two things, right? So the differences between suprabony and intrabony. Where are they? Yeah, we have them here. So table 27.2. It's very easy to understand. So first we'll see each point comparing supra and infra as given here in the table. Base of the pocket is kernel to level of alar bone in suprabony pocket, right? Whereas base is apical to crest of the alar bone in case of intra or infrabony pocket. Next, second parameter. The pattern of destruction of underlying bone is horizontal in case of suprabony, whereas it's vertical or angular in case of infrabony or intrabony. And the third difference, the transeptal fibers are arranged horizontally in space between the base of the pocket and alar bone. Just remember, the transeptal fibers are horizontal in case of suprabony pockets and they are oblique in case of infrabony pockets. And also the periodontal ligament fibers beneath the pocket follow their normal horizontal oblique course in case of suprabony pocket, whereas the periodontal fibers follow angular pattern of Ibsen bone. All these differences are mainly because of the pattern in which the bone is lost, right? So infrabony pocket, it's more deeper, it's more vertical bone loss comparatively than the horizontal one. So we have these subtle differences. And then we have finally gingival abscess and periodontal abscess. So periodontal abscess is nothing but a purulent material, localized accumulation of purulent material or pus is called as abscess, right? So periodontal abscess is localized purulent inflammation in periodontal tissues, also known as lateral abscess or parietal abscess. These synonyms are very important, right? So periodontal abscess, also called as lateral abscess or parietal abscess. And whenever the supporting tissues are not involved and when there is pus accumulation only in the periodontal, only in the gingiva, then we call that as gingival abscess. So abscess localized in gingiva due to injury of the outer surface of gingiva and not involving the supporting structures are called gingival abscess. Gingival abscess may occur in presence or absence of periodontal pocket. So we have few radiographic pictures and histopathologic pictures. So periodontal abscess may form either because of extension of infection from the periodontal pocket deeply into the supporting periodontal tissues, the abscess formation, or due to lateral extension of inflammation or formation in a pocket with a tortuous course around the root, it is cul-de-sac. Cul-de-sac, as mentioned in the third point, it's nothing but the bottom of a bag. So bottom of a bag, it's closed, right? The top end is open. So there can be formation of, the periodontal abscess may form cul-de-sac, the deep end of which is shut off from the surface, which is seen in case of spiral pockets when there is tortuous course around the root. And also these periodontal abscess can form because of incomplete removal of incomplete removal of calculus during treatment, and also because of lateral perforation of wall or trauma to tooth during root canal treatments, right? So these are some of the reasons why periodontal abscess can form. You can have a question like all of the following can lead to periodontal abscess formation except. So you can expect such questions from these topics, right? And finally we have periodontal abscess classified as abscess which is present in supporting periodontal tissues along the lateral aspect of root, and abscess that is present in the soft tissue walls of deep periodontal pocket, right? So that's all fine. We have a small brief classification. And finally we have this periodontal cyst, which is formed because of odontogenic cyst caused by proliferation of epithelial cells of Malacus, lateral dentigerous cyst, primordial cyst, stimulation of epithelial rests of periodontal ligament. All these can lead to formation of periodontal cyst, which is usually asymptomatic without grossly detectable changes, right? So radiographically we have cyst appears on the side of the root. That's how we can differentiate that from the periapical cyst. We have this cyst, since we're calling it as cyst, we have this radiopaque border. That's fine, right? So you have this clinical picture of periodontal abscess. Let me just conclude with that one picture. I hope you can see this picture, right? Yeah, here you have periodontal abscess, which is seen on the attached gingiva, as you can observe here, right? In the supporting areas. So that's periodontal abscess on the upper right central incisor. 1-1. Would you like to see the infrabony pocket clinically? We have one clinical picture. Yeah, as you can see here, let me just zoom in. Yeah, here you go. So we have intrabony or infrabony pocket on the molar region, right? So after raising the flap for treatment for infrabony pockets, the vertical bone loss around the mesial roots of mandibular first and second molars can be seen. So we have more of vertical or angular bone loss, right? So this completes our extensive topic, the periodontal pocket, which is huge, vast, many important points to understand and remember, right? So somehow we could complete that in 60 minutes, less than 60 minutes, right? Yeah, periodontal abscess is also seen mostly on the lateral aspect. If it is present on apical, we call that as periapical abscess. Periapical abscess, the main common reason or implication would be endodontic origin, not periodontal. So periodontal abscess or cyst most commonly seen on the lateral aspect of root. Sadhana, you say, is there any video explaining the flap and mucogingival surgery? No, we haven't really as such made any video in periodontics. By the way, we are doing a lot many recorded videos in perio as well. We have been uploading them to e-classes as and when necessary and possible. And regarding explaining flap and mucogingival surgery, we have one video on endodontic microsurgery. You can just have a look at that video. It's there in endodontics. Endodontic subtopic in our e-classes. You can find a video on endodontic microsurgery. So in that video, I've shown you one recorded video of, in the video, I've shown you another video of Libya oxenbean flap and few other flap designs. You can just have a look at that. It's also there in YouTube, I guess. Anyways, you can find that in e-classes. And anyways, we'll try to make few videos on flap and mucogingival surgery. Periodontal abscess, the treatment is elimination of etiology, as you rightly mentioned previously, elimination of plaque, elimination of pocket, right? Scaling, root planing, antimicrobial therapy. We have these phases in treatment, right? Phase 1 to phase 4, which we'll discuss tomorrow morning, right? By the way, in multiple choice questions. Scaling and root planing? Yeah. Yes. We have something called as curettage, right, Regina? Dental floss is useful. See, dental floss is very useful for removing interdental deposits, right? Interdental cleaning and all. Yes, dental floss is still, it is still relevant. But I've seen few news articles, not the journal publication, but I've seen few news articles claiming that this is obsolete method. But however, as per the literature, flossing is advisable, has to be advised, right? If you ask the same question to a periodontist, you will definitely get angry. So, because they love floss, right? Yes, Regina, during flap surgery, we should remove all deposits as well as sulcular epithelium. That's called as curettage. Curettage is soft tissue scraping, removal of all diseased tissue. And also root planing, right? Remove all diseased stuff on the cementum. Bernice, abscess, just antibiotics are not going to help. We need to initiate mechanical removal. As such, even in periapical abscess or periodontal abscess, antibiotics alone will not help. We have to intervene. Yeah, right? So, have any further questions? And as I started this session with one quote, I'll just conclude the session with the same quote. So before that, I'll just take few more questions. So I was actually expecting another 30 minutes to complete this session, but somehow I just rushed through the important points, right? So hope you made a note of all these points. And tomorrow morning we're going to have a live session on multiple choice questions exclusively from Perio. And day after tomorrow we're going to have image based questions from Perio, right? And Saturday one general topic, as I've shared already in our WhatsApp group as well as on Facebook. So how is it going, your preparation and all? So how is the climate on your side? It's raining here for the past 2 days. It's comparatively cool here. Prajakta, as such, I'm not sure if betadine is contraindicated for cleaning abscess, but usually we use this antiseptic solution during irrigation process. Prajakta, anyways, I'll just make a note of this question and I'll just cross check with the literature, with the existing literature, right? Irrigation of betadine. Because I've seen many cases clinically where they drain the abscess and then irrigate the abscess, or they irrigate the cavity with saline, normal saline, and also with betadine. Yes, they do. But anyways, I'll just cross check once and I'll let you know. I'll let you know in the comments below after the video gets uploaded to YouTube, right? Okay, Prajakta? Prithvi. Prithvi, it's very simple. See, attachment loss will measure from the base of the sulcus. That's what is mentioned in the literature. So attachment loss, a pocket depth is from the base of the sulcus, base of that existing deep-end sulcus and the gingival margin that gives you the periodontal pocket. Attachment loss, we take only the base of the pocket as a standard reference. We have this mucogingival line as reference as far as I remember. I remember my prof telling me. But anyways, I'll just refer the literature and get back to you with more authentic information, Prithvi. Is it fine? So pocket depth, I'm quite sure. It's from the gingival margin, the crest of gingiva and the base of the pocket. And attachment loss is from base of the pocket to mucogingival line or some standard anatomic reference. Anyways, I'll refer and I'll let you know. Viral videos, Cloudy. So viral videos, you are from my place. Okay. Mega Jain, biologic width. You can find in E-classes, Mega. Anyways, biologic width is nothing but, let me just show you in the image. It will be much more clear. Can you just have a look at this? Yeah. I hope it's clear. Okay. Yeah, it's from the CEJ. I'm sorry, I said mucogingival, I'm wrong. It's from the CEJ. Yes. Anyways, Ramesh, we'll just get back to that. Yeah, here you can see. Mega, is it clear? Let me just decrease the brightness or somehow. Just give me 1 second. Yeah, the standard reference is CEJ. I think I'm able to recollect that now. I think it's clear now. Yeah. So this junctional epithelial attachment, consider that this is a normal one, normal sulcus, sulcular depth. So this is epithelial attachment, which is approximately 0.97 in normal case scenario, and the subjacent connective tissue attachment of 1 mm. So that's called as biologic width. Biologic width has to be maintained, or else there will be periodontitis or there can be plaque accumulation. While doing crown cuttings and all, we need to respect the biologic width and maintain a minimum of 2 mm space from the base of the gingival sulcus to the crestal level, right? So that's the biologic width, which comprises the epithelial attachment and the subjacent connective tissue attachment to the tooth surface, right? Hope it's clear, Mega. Anyways, we discussed extensively in our E-classes. You can just have a look at that. Yeah, attachment clause is from the base of the sulcus to CEJ. So we have the answer here, right? Yeah, I was wondering, it's a soft tissue landmark. Anyways, it's CEJ. Bingo. And thank you, Ramesh and Bernice, for helping me out. Bernice, you say no raining at all. It's raining here for the past 2 days. Maybe it's extremes. So attachment loss is calculated from the base of the sulcus to CEJ. Yeah, from the CEJ, based on the amount of attachment that's lost, depending upon the base of the sulcus, we get that attachment loss. Prithvi, I hope it's clear now, right? Is it Prithvi who asked this question? Yeah. So pocket depth, as usual, from the base of the pocket to the gingival margin or crest of gingiva. Attachment loss from the CEJ to the base of the sulcus. Viral video, sir, from Vijayawada. Okay. Fine. I have one software. I have created one software.